Hello, welcome people. In the last video, we looked at the HIV pathogenesis, mode of transmission, receptor attachment, replication, immunopathogenesis, kinetics of immune response, opportunistic infections. So we have seen the first 3 points. In this video, we want to cover the next 3 points, hopefully. So basically in transmission, we saw that the risk is maximum in blood transfusion. Ignore that. Coming to the percentage of total transmission, maximally it is transmitted, transmission is maximum by sexual intercourse, 75 to 80%, okay? And in that, vaginal is maximum, and then anal, and then oral. Blood transfusion, parent to child follows, right? Sexual intercourse and then parent to child is maximum, actually, the transmission, okay? Then, moving on, we saw the receptor attachment. We saw that in the HIV there are glycoproteins GP120 and GP41. GP120 is going to help to bind to the host. 41 is the fusion protein which is going to help this binding between GP120 and the host cell. Host cell has two things, that is main receptor is the CD4 and secondary receptor will be the CXCR4 in helper T cell. In other cells it is going to be CCR5, okay. So the GP41 is going to bring about the fusion of this GP120s, this CD4 receptor and some secondary receptor. So basically this type of receptor is present in monocytes, mainly T helper cells, monocytes, macrophages, Langerhans cells, astrocytes, keratinocytes and glial cells. And even in dendritic cells, they are there, but in dendritic cells the virus won't invade the cell. Virus is only attached to the dendritic cell and the dendritic cell can carry this virus to the lymphoid organs, okay? So that was what we studied in receptor attachment. Now let's move on. We saw replication of the virus. This is not difficult either, don't worry. So basically we already told you the fusion happens between this GP120, CXCR4, CD4, etc. and the one that helps is this GP41, which is the fusion protein. Then once this virus has fused, now it is going to enter. The viral nucleocapsid is going to enter, not the entire virus, just this entire nucleocapsid enters and then the nucleocapsid opens up. It will expose these 2 copies of RNA and this reverse transcriptase enzyme. So now what happens? This reverse transcription happens. The RNA, the single-stranded RNA becomes single-stranded DNA, becomes double-stranded DNA. Now, double-stranded DNA makes some proteins that are required for the virus. Then what happens? There's a pre-integration complex of this double-stranded DNA, the GAG matrix protein, the accessory VPR protein, and viral integrase. Viral integrase you should not forget. So this is the enzyme that helps the virus to bind to our chromosome. So this pre-integration complex, now what happens? It enters the nucleus. See, this is the T helper cells. Now this is the nucleus. Now this this pre-integration complex has entered the nucleus. Now once it enters the nucleus, it is going to bind with our chromosome. It's going to integrate with our chromosome. This is called as the viral integrase, right? This is with the help of viral integrase enzyme. Now what happens? This entire T cell, what you're seeing with this viral DNA mixed with our chromosome, this is called as a provirus. So what is provirus? Provirus is this thing where the double-stranded DNA of the virus has integrated with our chromosome with the help of viral integrase enzyme. Then it goes into latency. For a variable period of time, the virus may go into latency. So this is what we saw in the first 3 steps of pathogenesis. Now we have to move on to immunopathogenesis. Now what starts happening? Following this infection, okay, the HIV is carried to the lymph nodes and other lymphoid tissue where further multiplication occurs inside the T cells. Acute retroviral syndrome, right? Yeah. So basically now what we are talking about, the virus is carried to the lymph nodes and other lymphoid tissue, right? And there it starts multiplying inside the T cells. Virus multiplies inside T cells in the lymphoid organ. Okay. So that is what has happened now. Guys, take a deep breath. we are looking at the pathogenesis, immunopathogenesis. Here we saw that the virus inside the T cell, it multiplies in the lymphoid organ. Initially what happens, the HIV destroys the infected T cells and spills over into the bloodstream, causing primary viremia. So there is primary viremia. Right? So what happens? The virus spills over to the blood. It destroys this T cell, comes out of it, spills into the bloodstream and causes primary viremia or acute mononucleosis-like syndrome. It coincides with initial flu-like symptoms, right? And in many patients, this occurs 2 to 3 weeks after the primary infection. So it's just like some flu-like illness. Are you able to see? Flu-like illness. Flu-like illness 3 to 6 weeks after primary infection. Okay. So this is called as primary viremia or acute mononucleosis-like syndrome. Acute mononucleosis-like syndrome. Okay. So we are done with this. Then what happens in this initial part, there is significant drop in the number of circulating CD4 T cells, okay. Now let us move on to the asymptomatic stage. Now adequate immune response develops within 1 month of most of the patients. So our immune is able to respond to this virus. Both cell-mediated immune response and humoral response come into play. So what happens? Viremia drops down. Now what happens? The viremia drops because our immune is taking over, right? So there is immune response, both humoral and cell mediated, right? So the viremia drops down, right? And the CD4 T cells, again they become normal. CD4 T cells, the count becomes normal. Okay. It is important to note that this is a state of clinical latency, but not microbiological latency. Clinically it is latent, yes, but microbiologically the virus are not latent. Okay. But virus are not latent. Okay. The virus are planning something, it's coming. Like they say, na, before the storm comes the calm, like that. The immune response cannot clear the infection completely. Okay, the HIV infected cells persist in the lymph nodes and there is high level of ongoing viral replication. So now what is happening? We just make another place here. There's no place here. So basically what happens? The HIV infected cells persist. Okay, they persist in the lymph nodes and there is ongoing viral replication. It's happening. The virus are silently replicating. Remember, it only clinically it is asymptomatic. Clinically it is latent. Okay. Now viremia drops down. Viremia reduces. Okay. Then continuing in the asymptomatic stage itself, the period of clinical latency is variable, may last for 10 years also, okay? For few months this can be there. How long this can be there, guys? Few months. Can I write it here only? Few months to 10 years this can happen. Asymptomatic stage. Okay? In the first, how much you saw? 3 to 6 weeks after. This is 3 to 6 weeks after infection, this person gets a flu-like syndrome. Then asymptomatic stage where the clinically there is latency but the virus are multiplying. This can happen from few months to 10 years. Okay, then again here itself in asymptomatic stage they are explaining something. Once the latency is broken, the disease progresses rapidly and death usually occurs within 2 years if left untreated. Oops, it's quite scary now. Now the virus came out of latency. Actually it is not latent, okay, the virus is replicating only. Clinical latency is there, that's all. Okay, it's only clinical latency. So only the clinical symptoms are latent. The virus is actually not latent. Even in the previous stage where we put latent, right? Here, in replication, just put here latency, only asymptomatic, but virus are actually replicating. In this replication, just add that point. This latency doesn't mean that the virus are just sitting in dormant stage. No, they are replicating. Okay. So that is a asymptomatic stage, few months to 10 years. But once it comes out of this latency, it is going to cause death within 2 years. Okay. So we'll write that here. Once the virus comes out of latency, rapid progress of disease and death within 2 years. Okay. Very good. Shall we move on to the next point here? In immunopathogenesis, persistent generalized lymphoadenopathy. So, we are looking at the third point, guys, in this immunopathogenesis of HIV, persistent generalized lymphadenopathy, PGL. As a result of HIV replication in lymph nodes, 25 to 30% of infected people who otherwise are asymptomatic develop lymphadenopathy. Okay, because of this virus replication inside these T cells, inside these lymph nodes, so many people will develop lymphadenopathy, obviously, but they are asymptomatic. Obviously, right? Everything you understood, no? So, PGL is defined as enlarged lymph nodes more than 1 centimeter in size and they are not in contiguous sites. Like the lymph nodes are not contiguous. One lymph node somewhere, all these are enlarged. And they persist for at least 3 months. So this is the definition of PGL. PGL must be distinguished from other causes like lymphoma. You should not confuse it with lymphoma. So what did you understand here? Enlarged lymph nodes. Patient is asymptomatic of HIV. So enlarged lymph nodes, what type of enlargement? You should say greater than 1 centimeter in size. Okay, in 2 or more you are not able to see, 2 or more non-contiguous, okay, non-contiguous sites, right? And they persist, this enlarged lymph nodes persist for at least 3 months. So, did you understand the PGL? PGL means what? Patient is asymptomatic, but the lymph nodes are enlarging. Why? Why the lymph nodes are enlarging, guys? Because of virus replication. Because of virus replication. So, how do you define PGL? 1 centimeter, more than 1 centimeter in size. The lymph node will be more than 1 centimeter in size. And this enlargement will be in 2 or more non-contiguous sites, persists for at least 3 months. That's all. And don't get it confused with lymphoma. That's all. Now let us move on to symptomatic. Symptomatic HIV infection. That's all, guys. Don't worry. Now we are already at symptoms. Now what happens? After a variable period of this latency, the CD4 T cell level starts falling. Usually what will happen, CD4 T cell level is falling. The patient develops constitutional symptoms such as unexplained diarrhea lasting more than 1 month, weight loss more than 10% of body weight, fatigue, malaise, night sweat. Wow, night sweat. Mild opportunistic infections such as oral thrush. Oral thrush is caused by what? Candida. Okay, so what and all you understood now. After this variable period of latency, this person started getting some symptoms. What symptoms did you understand? Diarrhea. We read diarrhea. Then what and all we read? Something like opportunistic infections. Then what else he is getting? Night sweat. Yes, we read that also. Night sweat. Then what did you read? Go back and check that. We explained some unexplained weight loss. More than 10%. Unexplained weight loss. More than 10%. Okay. They didn't explain the duration, but okay. Night sweat, fatigue, all that you should write. Fatigue. Okay. Mild opportunistic infections, they are saying. This is mild opportunistic infection. At this point, they are not saying it is severe. It is just a mild opportunistic infection. Is it clear? Mild opportunistic infection. This diarrhea, unexplained, lasting more than 1 month. Okay, unexplained diarrhea. Everything you put off here. Unexplained diarrhea lasting more than 1 month. That's all, guys. So let's move on now. Oral thrush example. Oral thrush. THRUSH only, yeah. Example is oral thrush for opportunistic infection. That's caused by candida, guys, inside the mouth. Now let us move on to the last part here, AIDS. Now what happens? The patient moves towards the advanced end stage of HIV infection called AIDS. Rapid fall in CD4 T cell count, usually less than 200 cells per microliter. That is what they will call as AIDS, you know. CD4 T cell count less than 200 cells per microliter. Okay. So this is, you can call it as AIDS. High virus load. Virus is more, CD4 cells are less. Lymphoid tissue is usually destroyed. Gone case, all our lymphoid tissue is already destroyed and it is replaced off with fibrous tissue. Opportunistic infections are not mild. They are in secondary to profound immune suppression. There will be opportunistic infections like opportunistic infections. Let's just shift focus here and go to opportunistic infection slide. This one. So the opportunistic infections the person developed is bacteria infection like tuberculosis, fungal infections like candida, pneumocystis cerevisiae, virus like herpes virus can cause mucosal lesions, cytomegalovirus can cause retinitis, parasites such as cryptosporidium parvum diarrhea it can cause, and toxoplasma can cause encephalitis. Okay. So is this clear? So these are the opportunistic infections, very important for exam also. Learn these names. Bacteria will cause TB, fungus will cause virus. Let's put the virus next, right? Bacteria ke baad virus only we write all the time. Bacteria, virus. Virus is herpes virus, herpes simplex, mucosal lesions, cytomegalovirus, retinitis. Coming to fungus like candida, obviously candida. Then pneumocystis cerevisiae. Then parasites like cryptosporidium parvum will cause diarrhea. Toxoplasma will cause encephalitis. You know toxoplasma's full name? It is Toxoplasma gondii. Okay. Toxoplasma will cause encephalitis. So let's go back to AIDS. So AIDS is the end stage of HIV. Here, there is high virus load, right? There is high virus load. Pay attention here. There is high virus load. Let's make some place here. So there's high virus load. CD4 count is less. We have already mentioned that here. CD4 count is less than 200 cells per microliter. Then the lymphoid tissue is totally destroyed and replaced with fibrous tissue. Lymphoid tissue is totally destroyed and replaced with fibrous tissue. Okay. Then opportunistic infections are all there. Development of neoplasia. This person can develop neoplasia, that is cancer, and there can development of direct HIV induced manifestations such as HIV encephalopathy also can happen. So what and all will be here in this, some more are there. Opportunistic infections, okay, no place here, we'll make some place with it. Opportunistic infections, guys. Opportunistic infections, right? You can list all those opportunistic infections, whichever we told you. This person might develop malignancy like CNS lymphoma. This is CNS lymphoma. Lymphoma, okay. CNS lymphoma. Then HIV encephalopathy. See, all this person is developing. These are the features of this AIDS, that is the end stage of HIV. Okay. So is this clear now? Shall we move on? So we are done with immunopathogenesis, right? We are done with immunopathogenesis, guys. In the pathogenesis, immunopathogenesis is done. Just go back here. What and all we have seen so far. So in pathogenesis, we have seen the mode of transmission, receptors, replication, immunopathogenesis, opportunistic infection also we have seen. Now we have to look at kinetics of immune response. In kinetic of immune response, what exactly will you see? How viremia happens, how our body responds, humoral response, how it is, how structural components are strongly immunogenic, how there is window period, antibodies to GAG protein, antibodies to P24, anti-HIV antibodies, a little about them, okay? Let's look off now only, why look up later. So basically understand how our body responds, okay? Viremia, as soon as the virus enters the body, there will be viremia, you know this, and P24 antigenemia. Wow, viremia and P24 antigenemia. Where was this P24, guys? Go back and see where this P24 was. P24 is the principal core antigen. Okay, so it was the GAG gene which produces this. So basically go back to this one and say this is nothing but the principal core antigen, right? Against it there is antigenemia. In the blood there will be this antigenemia. Then humoral response, there is formation of antibodies of different classes like IgM, IgA, IgG are also formed against all these proteins, okay? Regulate against all these proteins, obviously it is creating antibodies, okay? IgM, IgG, IgA, all these are produced. Then structural components are strongly immunogenic, that is the HIV structure, you know, right? They will induce the formation of antibodies. Whereas immunogenicity of regulatory and accessory proteins is variable. That you leave, okay? Against the structure of the virus, we make lot of antibodies. Coming to window period. What do you mean by window period? Following the infection, antibodies appear in serum only after a period of interval, which is called window period. This is about 3 to 12 weeks. Okay, 3 to 12 weeks. That is period from infection to antibodies in serum. This is the window period. That is 3 to 12 weeks. Antibodies to GAG protein against P24 and P55, they usually appear first. All this is, I think, a little too complicated. Antibodies to P24. As the disease progresses, antibodies to P24 usually declines. Okay. Then anti-HIV antibodies. So, amongst the antibodies IgE, MG and A, only IgG response is consistent and long lasting. As usual, right? It will last long. Most available assays, they try to detect IgG antibodies. Okay. So, I think that's all we wanted to cover in the kinetics of immune response. Not very difficult, right? Guys, it was pathogenesis is done. Don't worry. Everything you have understood. There is, now let us look at the pathogenesis again. So we saw that mode of transmission, how it enters, how we get the disease. Then receptor attachment, we saw how there is a primary main receptor and then secondary receptor and these fusion proteins. Then how it enters the host and how it replicates there, how there is something called as pro-virus that is created. Then what happens into our immunopathogenesis? Basically in immunopathogenesis you saw so many steps, right? Go there. Immunopathogenesis, you saw that there is a flu-like syndrome. First there is a flu-like illness, then there is an asymptomatic phase where the clinically it is latent but the virus are actually not latent. Then you saw the PGL, that is the persistent generalized lymphadenopathy, where all the lymph nodes, they become large. These are non-contiguous lymph nodes. Then symptomatic HIV infection, this is AIDS related complex, ARC. Here there is unexplained diarrhea, mild opportunistic unexplained weight loss, fatigue, night sweats, etc. Then comes AIDS. It's the end stage where there is high virus load. The CD4 count has gone less than 200 cells per microliter. So obviously the immune has been attacked. So there are opportunistic infections, neoplasia, HIV encephalopathy can happen. The lymphoid tissue is totally destroyed and replaced with fibrous tissue. So basically, if we have not said this already, what exactly happens in HIV infection is that the immunity of the body is hit. That is something that you have to highlight and tell people. The immunity of the body is hit. The T helper cells, the CD4 T cells, which are going to help in immunity, they themselves are attacked. The macrophages are attacked. So basically, the body's immune system itself is attacked. So that is the pathogenesis, where you have to explain that all this happens and the immunity of the person goes down. That's why it is called as AIDS, acquired immunodeficiency. What is AIDS? Immunodeficiency, right? So what is AIDS? That itself we didn't write here. Acquired. Why it hates me to, it hates if I make it like that. What is AIDS, guys? Acquired immunodeficiency. Acquired deficiency syndrome. Okay. So that was about the immunopathogenesis. Then we saw the kinetics, where there is a window period. Then the body makes IgM, IgG, IgA, all these antibodies. Then the HIV person is prone to get these opportunistic infections. In the next video, what will we look at? So just take a clue of what we will look at in the next video. We will look at the lab diagnosis in newborn, then treatment, okay, post-exposure prophylaxis for people like us, health workers, if we get a needle stick injury, what to do, etc. Okay, so come back for the next video, take a break, enjoy, and then take rest and come, okay, bye-bye.